Okay, so this is the second part of the SimChart navigation that I'm going to be going over with the students. So the first part was the patient clinical information, and then the preclinical manager. This is primarily the patient charting section, and possibly the rest of the areas, depending on how fast I can get through it. So to continue from where we left off, we finished the preclinical manager here, which in my opinion takes the longest amount of time, just because I like for it to be a little bit more detailed, because this is where all of your learning is going to come from: your diagnoses, your patho, your pharmacology, and what labs go where. The next section, this is what I was trying to show you guys earlier. This is what was sent to us by Professor Pulowski, and I'm not exactly sure where it came from, but this is what is required for Nursing 321 clinical documentation. So what I did is I used this for what the school requires, and I expanded on it just a little bit further, just to kind of help you guys so that you know where to go and what each section means. So the next section that I'm going to go off of is the patient charting. This is where all of your patient information is going to go, and it can be a lot of information. So for my students, I am primarily requiring the symptom analysis and the complete physical assessment, and then each assessment. So symptom analysis is, the admission history can kind of get tedious because you have patients who've been in the hospital multiple times. This is not hard to find in Cerner. However, at this level, I don't feel like it's an absolute essential part of what you need to know, because it's kind of redundant at some point. The system assessments is more what I feel is more important, just because this is where you're going to start expanding on your head to toe for this semester in particular. So your head to toe, this is going to include every section within your head to toe that you're going to have to be tested on at some point. So symptom analysis, I wrote here pain, presenting complaints, whatever it is that brought them into the hospital. For this patient, I'm going to put chest pain and shortness of breath. We'll say mid-substernal, quality, dull, severity, we'll say 10 out of 10. Associated signs and symptoms is going to be the shortness of breath, we'll say diaphoresis, and anxiety. And then timing, I'm going to say 2 hours ago, 2 hours prior to arrival, or to be more specific, we'll say, I don't know, 11 a.m. And then context, it just kind of depends on what is available in the chart, but context can mean multiple things. Modifying or alleviating factors, I'm just going to put rest, and we'll say, I don't know, oxygen. And then interventions, given nitro, sublingual with relief, O2 at 2 liters with 98% saturation. Patient reports the worst pain he's ever experienced. I don't remember if I made this a male or a female. You can go into more detail there. Now, for complete physical assessment head to toe, this area is if you have, it's kind of more like what we call charting by exception, which you will learn at some point. For this level, I don't feel like you need to know this part just yet because I feel like you learn more on the next section. So I'm going to ask you to click no assessment required at this time, and that grays everything out so that you're not forced to fill anything out in there, because it can become a lot when you're having to write different things such as in no acute, or we'll say in moderate distress, integument, clean, dry, intact. For cardiovascular, we'll say tachycardic. So there's lots of things that you could type in here, and until you get familiar with the verbiage, you're not going to really know what to write. So I say to go here, do your assessment. This is what we assess on our patients every shift. So we're going to say irregular apical heart rate, no murmurs. This gets to be very time consuming because you are literally going into each section. Oops, I just clicked out of it, sorry. And this is really what it is in the hospital. So it gives you good experience on documentation and what you can be expecting in the future. It is a little bit more detailed than what is realistic, but at this point you're learning, and I think that it's important that you understand what the expectation is. Obviously, if you did not document it, it didn't get done, so it's important not to skip out on any of these areas. It gets to be a little bit faster the more you go, and we can just say regular, for most of them. Now, this ankle brachial index, most of the time you're not going to see it unless you're in the ICU setting, so I'm not requiring that for me right now. Warm extremities, or we can say pale, maybe discoloration of legs, and then generalized non-pitting edema. We'll say cap refills less than 3 seconds in all extremities. And again, this is really just cardiac, so it can be very, very time consuming. We'll say slight pitting edema. Oh, well, I already wrote non-pitting right there, so we'll leave that as is. And we'll say tachycardic. He's on telemetry. We'll say the upper limit is maybe 120 and the lower limit is 50. The rhythm you're really going to find in the telemetry strips. This is in the documentation. The cardiac monitor isn't really going to apply unless you're in the ICU setting. Then you just kind of work your way down until you get to the bottom. Respiratory, you're going to fill out all the lungs. Now, for your initial head-to-toe assessment, every assessment is going to be required, so there's no reason why you should be clicking no assessment required at this time. Unless, however, you are in a procedural area, or you're in a emergency department where, say, the patient came in with an MI and you didn't necessarily assess their skin or, something like that. But for the most part, you're going to have every assessment filled out for your patient, for your initial assessment, and you're going to just work your way down. Okay, so for the sense of time, I'm not really going to go through all of this, but I do expect that you guys at least get comfortable with the wording and the documentation, because all of these are literally expected in nursing when we chart in real life. So it does seem tedious, but I promise you it is pertinent at some point in nursing. You're going to work your way all the way down until you get to the end, and the psychosocial assessment is kind of where things get to be a little bit more, related to things not necessarily nursing. I mean, psychosocial is nursing, but not necessarily your physical assessment part, like your lung sounds, your heart sounds, things like that. So we're assessing the patient's psychosocial status, asking them these questions and how much they understand them, if they feel like they have support, things like that. This is what's going to trigger social services involvement and discharge planning. Say they have mild anxiety and patient has a good social support system at home, and hopefully it's going to let me move on because I didn't fill in all the boxes. Safety assessment, this is really important. I require every single patient to have a safety assessment. Safety is one of the most important, critical components of our job, and this is how we justify that we've ensured our patients were safe in the hospital. So our Morse fall scale is required, and the nice thing about this is that when you click on this link here, it actually pops it up for you. So you don't have to calculate it on your own. You're literally just going through, has the patient fallen? Do they have a history of falls? You can say no or yes. You can find that in the chart or just by simply asking the patient. Do they have a secondary diagnosis? More times than not, they will have a secondary diagnosis. And then if they use a walker, or if you have to help them walk, if they use crutches, or if they're holding on to furniture. Now, if they're on bed rest or they're completely independent, then that's obviously a 0. Most patients have an IV, so that's always going to be yes. And if they're weak, or are they alert oriented, or sometimes they forget that they can't walk or that they're a little unsteady. And that pops up your score here, 45. So then based on our score here, our patient is a high risk for falls. And now you need to justify your fall risk scale. So what did we do for this patient? We put a fall risk band, we have their hospital ID bracelet, and then we can also do other like bed alarm, Q 1 hour rounding, education, slip resistant socks, etc. Now you go down to save. Okay, so it wants me to save complete charting and psychosocial. So let's go see what it wants here. Oh, it wants me to fill out the psychosocial. So for this, I'm just going to put none because I already went over this with you, and think you get it, hopefully. Okay, so good. So it saved my systems assessment. So at this point, all this area should be completed, and we should be at our discharge planning. So I'm going to highlight this red. And I came down from system assessment to discharge planning. And discharge planning starts at the time of admission. So it's, even though we don't necessarily know what the discharge plan is going to be, we need to at least start looking into it from when the patient arrives. Now, this is a little bit beyond what you guys will need to be doing in 321, but as you progress, then you will start adding to this a little bit more as you go. So you can just answer the questions the best to your ability. Sometimes just in talking to the patient, you can get a lot of this information and just go through it and fill it. Sometimes the patient needs to go to a skilled nursing facility. I think you get it. Okay, now nursing interventions is very important, and discharge summary I'm going to skip just because I don't think that you need to know this part yet. This is more along the lines of what the doctor fills in whenever they put their discharge orders in. The system nursing interventions, it's a little redundant because it goes back to your head to toe, and it's asking you what interventions were done in each section. Now, if it doesn't apply to your patient, then you don't have to really do an intervention. So if the patient wasn't there for neuro disorders, then there's no interventions that really apply. If the patient, will say peripheral vascular and cardiovascular, there were lots of interventions that we did here. So we had the patient on telemetry, we had them on bleeding precautions, we had them say on a cardiac monitor. We had their extremities elevated because they were edematous. We encouraged rest. We did lots of things here. So you definitely want to give yourself credit for the things that you're doing with your patients. Even though we don't necessarily realize what we're doing, we need to document that we're doing them. So we promoted these things. We used stockings. Maybe we used SCDs or sequential compression devices to prevent further blood clots. And we educated the patient on foot pumps, moving their feet so that they don't get blood clots. And then what was the patient response? So did their edema improve? Did their blood pressure improve? No complaints of chest pain, etc. I think you get it. I'm going to save that because the patient was mostly cardiac. And obviously if the patient had other things going on, then you would include those here. But in this case, I'm just going to stick to our cardiovascular. Basic nursing care is going to be your ADLs, your safety, hygiene. Did you help the patient go to the bathroom? Patient was oriented to the room. They had their side rails up. Their wheels were locked. Again, you should always have call light within reach, bed in low position. Fall prevention education is always happening. Toileting every 2 hours. Their bed alarm and chair alarm was on. And then this is more for like if the patient was on suicide risk or elopement risk or danger to themselves or others. Again, you just go down and figure out what is pertinent to the patient. We can say the independently and ambulate. turn self, hygiene, they will say independent with mouth care, shave not applicable, we'll say we can assist them with their bed bath, dressing, we assisted them, if we changed their linens, if they were on isolation, which this patient probably would not be. And then nutrition, what's their nutritional status? Did they have, were they MPO? Were they able to feed themselves? Drink independently, and then they had their morning snack. Independent toileting, assisted to the bathroom, skincare, patient turned self, and save. Just kind of going through all this quickly. And we did these 3 things already. Now the special charts and the rest I'm going to do on another video. So I'm going to close out for this video. And then in the next video, you're going to see special charts and the remainder of this sheet. So bear with me and I will see you guys soon.